Hello and welcome everyone to tonight's PEP Talk. This is our final PEP for 2024. I can't believe how fast they've gone this year. And our topic for this evening is bleeding risks for anticoagulation users. And obviously this is such a critically important topic for those of us that are on anticoagulants, and also, family members or caregivers that are involved with a patient who's on an anticoagulant as well. So before we get started, I want to welcome both my PEP partner, my 7-time blood clot survivor friend, Todd Robertson, and I was at 8, I'm losing track.
I lost track. I don't keep track anymore.
And our clinical expert, Dr. Jacob Cogan. Jacob, do you mind if we call you Jacob? Because we're very informal here. We don't typically go by doctors, so if that's okay with you. Jacob joins us from the Division of Hematology, Oncology, and Transplantations. That's the first time we've had somebody in the transplant department at the University of Minnesota, where he practices as a benign hematologist, focusing on hematologic coagulation disorders. So a real expert here. And you are also an assistant professor at the University of Minnesota as well. Jacob received his BA in psychology from the University of Chicago. Would love to get your view on patients and their mental health experiences with blood clots. I don't know if you know this, but we have a big survey called the CLUE survey where we had 3,300 patients take it. They responded about PTSD and their mental health related to a blood clot. It's really fascinating. So as a psychology major, we'd love to get your viewpoint on it. Completed your post-baccalaureate pre-medical program at Columbia University in New York. Became a doctor of medicine at SUNY Downstate Medical Center, and completed your internal medicine residency at Columbia University Medical Center, and also your clinical fellowship in the Division of Hematology and Oncology at Columbia University. Big loss for Columbia that you took off from Minnesota. Jacob is double board certified in both hematology and internal medicine. And Jacob is the recipient of multiple research and scholarship awards. His work has been extensively published, so many times so that we would need another PEP to mention them all and go through them tonight. But we're delighted to have really you're a true anticoagulation expert, and we want to thank you for joining us on a Tuesday. So before we get started, Todd is our polling question expert. And so Todd, I'm going to hand it over to you before you kick it back to me.
Yeah, great. Thanks, everyone. Please be patient with us. We just want to get through these real quick, but they're really important. That's why we ask them. So here's your questions. Were the potential risks of bleeding due to an anticoagulant explained to you at diagnosis? Yes or no? If yes, by whom? Your doctor, your nurse, a physician's assistant, or a pharmacist? Have you ever had a bleeding incident caused by anticoagulation? Yes or no? And our fourth and final question, if on or prescribed an anticoagulant, which were you prescribed? And these are your 4 choices: Eliquis, Xarelto, warfarin, or just other. And that'll do it for those.
And then we'll get the results, hopefully.
And get the results, and then I'm going to hand it back to Leslie. Okay, here we go. So let me scroll back up. Were the potential risks of bleeding due to an anticoagulant explained to you at diagnosis? 60% said yes, 40% said no. If yes, by whom? 65% said doctor, 16% said nurse, 6% for the PA, and 14% said pharmacist. Have you ever had a bleeding incident caused by anticoagulation? 23% said yes, 77% said no. And if on or prescribed an anticoagulant, which one were you prescribed? 49% said Eliquis, 28% Xarelto, 13% warfarin, and 11% said other. Leslie, back to you.
So 40% did not have the potential risks of bleeding explained to them. That's terrible. Okay, Jacob, you have your work cut out for you tonight, I think. All right, so the first thing we wanted to kick off with you this evening was explain to us what an anticoagulant actually is. We all use this term blood thinner, but it doesn't actually thin the blood. But somehow we have this description of a blood thinner. And then why do the anticoagulants cause or increase the risk of bleeding? What's the science around all of this? And is there a difference in bleeding risk based on what anticoagulant you take? So a couple of questions in there for you.
Yeah. Thank you for having me. I'm really excited to be here and be talking about this. So you're right. The term blood thinner is a little bit of a misnomer, and I'll try to explain. So the body has a few natural processes by which it um, keeps the blood in a balance of between clotting and bleeding. So when you cut yourself, that's a situation where you would need your body to repair the wound and shift a little bit toward forming a blood clot, not the one like what we're all here for to discuss, which is a bit more extreme, but sort of a minor plug in the wall of a damaged blood vessel to fix it and stop the bleeding. And the main processes by which the body does that are through, you might have heard of blood cells called platelets, which is one. And then there's another process called the coagulation system, which is another process. And those two kind of work together to patch up wounds in the body and keep what we call hemostasis, or balance of bleeding and clotting. So when we talk generally about blood thinners, we're talking about a drug that affects the coagulation system of the body, which is this overly complicated cascade of proteins that ultimately form what's called a blood clot. And the drugs that we give, Eliquis, Xarelto, Coumadin, others, work on one or multiple different important components of that coagulation system and essentially block the system at that point or inhibit the system. And what that does is it decreases the body's ability to form a blood clot on its own. It doesn't completely stop it because the body has a few different ways that it can get to that end destination, but it significantly reduces its ability to do it in as timely or complete a fashion as it might normally. So generally, when we're talking about blood thinners, we're talking about a drug that impacts that part of the body's natural system. And I just wanted to add, I bring up the platelet component because you're obviously all familiar with the drug aspirin and drugs like that. Sometimes those are called blood thinners too, because they work on platelets, which are also involved. But I want to make the distinction because generally, and definitely in the situation that we're here to talk about, we're talking about treating blood clots where we need to have a drug that works on the coagulation system.
Right. Actually, it's a very important point that you bring up. And I know, Todd, you deal with this a lot in the group where people say, well, can I take an aspirin instead of taking a DOAC or warfarin or whatever it may be? Or I'm coming off of my anticoagulant and I was told just to take an aspirin. And there's a lot of confusion around that, how the body processes all of this.
Yep.
But I mean, it's true that, I mean, if you're taking a baby aspirin, taking an aspirin, it's somewhat effective for deep vein thrombosis prevention, correct? Isn't it something like, I've heard 30, 40% maybe, nothing like a true anticoagulant, but it does help a little bit. So maybe it offers itself as kind of a security blanket for people.
Somewhat. And there actually are some blood clotting conditions that are so serious that we want people on both a anticoagulant like Eliquis and aspirin. But in general, when we're trying to prevent the kind of blood clot that we're all here to talk about, aspirin generally is not good enough. We want the other kind of blood thinner, quote unquote.
So stay on what your physician is prescribing you, and let's leave aspirin out of the equation for the time being.
Right.
Okay, so the second part is, why does it cause or why does it increase the risk of bleeding? Just maybe go a little further into that.
Yeah, so because it's working to sort of block part of the cascade that the body goes through to eventually produce a blood clot, as a result, you are shifting the body a little bit more toward a tendency to bleed. Because if you can't fully form a natural, healthy blood clot, then your body is not going to fix a minor wound or something like that as quickly as it would normally, and you're predisposed a bit to bleed. And that's a risk that we kind of take on with this treatment because usually it's minor and patients live with it okay. Not always, but most of the time they can. And the benefit of preventing blood clots is enough that we think that trade-off is worth it. But that is far and away the major side effect of these drugs, is that you are sort of tilting the seesaw of the body away from a balance of bleeding and clotting toward a tendency to bleed, because you're shutting off part of the clotting aspect.
Okay. And then in the poll questions, we had asked folks, what anticoagulant are you taking? We asked Eliquis, Xarelto, warfarin, other. Is there a difference in bleeding risk based upon which anticoagulant you take?
Yes, there is. Not so major of a difference between the main ones we're talking about. Between Eliquis and Xarelto, I would say those are the same drug class. So there's not a difference between those two, except for some very minor or specific situations, which we may touch on later. Coumadin, which is sort of the tried and true long-term blood thinner that we've had until these newer ones came out recently, may have a higher risk of bleeding in certain situations because there's a little more variability in how Coumadin sort of its levels in the body. And that's why it needs to be monitored. And that's actually why we sort of prefer these newer drugs, because their effect in people's bodies is more predictable. But in general, I was looking at this before tonight. I think the estimate is that in a given, if 100 people are on these types of drugs for a year, 2 of them will have some sort of significant bleeding incident. So if that's helpful, about a 2% risk per year.
Okay. Which
Now,
sounds
go
low
ahead.
unless you're the person who's dealing with
Exactly.
the bleeding.
Exactly.
And I was just going to say, I hear a lot of patients, I see a lot of patients being more comfortable on something, on an anticoagulant like warfarin, because there is a readily available reversal. So I guess one of my quick questions is, I've heard about Andexa for Xarelto and Eliquis. I've also heard it's not in every hospital because it's so freaking expensive. I don't know if that's I don't know if that's a valid excuse or not, but is that reversal out there, and is there anything else they can do to stop the bleeding if you're on Eliquis or Xarelto and you go into the ER?
So there are reversal drugs available for Eliquis and Xarelto. It's a much different ballgame than with Coumadin, where all we need to do is give someone a dose of vitamin K, and that essentially reverses it, and that's cheap and easy. The reversal agents for Eliquis and Xarelto are expensive, and they sort of need to be handled by experts who know how to give it and can give it the right way. But they work very well, and they are available more and more so. And I can't speak to whether I would expect insurance to cover it or not, but they are available. And I find over time that I'm a little more comfortable telling people these are not drugs where you have to worry that there's nothing that can be done if you start to bleed, because the vast majority of bleeding will be able to stop without an intervention like one of those drugs. But in life-threatening situations, most places are going to have access to that kind of drug, and it can be given if needed.
Great. Okay. So Leslie, can I go ahead and start talking about bleeding?
Absolutely.
Can I ask? Okay.
We already went off course.
So can you walk us through 4 different types of bleeds with examples? Major bleeding, GI bleeding, minor site bleeding, and joint bleeds. How does the patient determine what is a major bleed versus not? And when should they seek medical help? And most importantly, how does one protect themselves from a bleed?
Yeah. So I'll start with sort of the most common, which are the more what we call minor bleeding that is common in people who are taking these types of drugs. So bruising, you bump yourself and you might get a bigger bruise than you would expect normally. Bleeding that doesn't stop as quickly as you would expect. So if you cut yourself shaving or something like that, you might find, oh, I would have expected, within a minute that would stop normally, but now it's going on a little longer than I might expect. And those are kind of the most common complaints that we see. And we don't see that in everyone. I would say if I have 10 people on Eliquis and Xarelto, maybe 2 people will say that they experience those kind of things. And that doesn't mean the drug isn't working. It just means that those are the kind of things when they happen that most patients experience, not most patients, but if there is to be anything, it would be those sorts of things. So then the next step up would be the GI bleeding, which is the most common, more quote unquote major type of bleeding that can happen. And that's where you're losing blood in your intestines. The intestines are pretty thin and they have a lot of blood flow in them. So they're very susceptible to damage from food, from the action of your intestines. And again, because the body doesn't plug it up like it would normally because of these drugs, there can be bleeding. So you might see red blood in your bowel movements. You might notice more commonly what's called melena, which is black bowel movements that can indicate that blood is in there and being digested. And that's the kind of bleeding that if any more serious bleeding is going to happen that could lead to someone needing medical attention, needing a blood transfusion in a severe case, it generally is going to happen from the intestines like that. Intracranial bleeding, I think you mentioned. So bleeding in your head is sort of the most serious and feared type of bleed that can happen. It's very rare, and it certainly isn't something that we ever see happen spontaneously in people. It's something that could happen if you have head trauma. Certainly, if you're somebody who had a brain tumor to start out with or something like that, you'd be at higher risk of that happening. And we get into that situation in people who have cancer who need to be treated with blood thinners. But so that is a situation. And again, I don't think that that's something that the vast majority of patients should ever worry about with the appropriate precautions, which I know we'll talk about. But if that were to happen, that's a situation where we'd want someone to get one of those reversal drugs to stop that bleeding as soon as possible. And then the last type of bleeding you mentioned is about joint bleeding. So that type of bleed is actually very uncommon with these drugs. That usually happens in a bleeding condition called hemophilia. And these drugs sort of create a predisposition to bleeding in patients, but they don't get all the way to causing someone to now have developed a bleeding disorder, so to speak. So that sort of bleeding, joint bleeding, muscle bleeding, things like that tend to happen only in people who have very specific diseases that have nothing to do with these types of anticoagulants. But the one thing I will say that's very important and very kind of maybe under-recognized is that these drugs can increase menstrual bleeding in women. And that can be a big problem that, people's periods get much heavier for much longer. People can become iron deficient as a result of that. So that's something we really try to pay attention to in women who are menstruating who are on these drugs.
Yeah, I think we want to talk about that a little bit later because that is a really big issue for a lot of women in the groups. So just before we move on, I just want to, so certain things that happen. The first time I got a nosebleed being on a DOAC, I thought I was dying. Like I thought I was bleeding to death, and eventually like it stopped, but that is just considered to be a low risk bleed then that I unfortunately got and many people got, and we shouldn't be concerned about that.
Not necessarily. I mean, so we, I guess, would classify it as a minor bleed, but it's not necessarily minor to you. And that's why it is good to have a relationship with your prescribing physician or provider to be able to talk about these things. Because for my patients who are on long-term blood thinners, I'm always trying to check in about this sort of thing because some people definitely need long-term blood thinners, and we need to find a way to deal with that bleeding. Maybe I would send someone to see an ENT or sort of some topical therapies to try to address that specific type of bleeding. But there's also some people who are on long-term blood thinners, but maybe they don't really need to be. Again, not saying that's your situation, but just something that I encounter where I'm always trying to see, okay, what's the balance between the help I'm giving by giving this drug and the harm that it's doing with bleeding, even quote unquote minor bleeding. And there's things we can do in terms of sort of referrals to people who can deal with specific kinds of recurrent bleeding like nose bleeding, but also some of these drugs like Xarelto and Eliquis, you can give a lower dose. And that lower dose can sometimes provide the same amount of protection against bleeding, against clotting while reducing bleeding, hopefully. And there was actually just some data at our national annual meeting that described that that practice actually maybe should be done more than it currently is. So again, we may talk about that later, but just to make the point that it's important to be in dialogue with a doctor or some kind of provider about this, because it's not a situation where you just have to deal with it. There's things that we can do to try to help.
So that's actually one of the things that we want to talk about next was timing and dosing. So you're newly diagnosed, you're put on an anticoagulant. Is that your greatest risk period of bleeding, that kind of like 0 to 30 days? Is it in the first 30 days post VTE? And you're typically on your highest dosage at that point in time as well. I'm not sure what the scale is to come down, but as your dosage is decreased, so I'm on Xarelto, I went from 20 to 10 to 10 milligrams. So my dosage is being decreased. Other people are having their dosages being decreased. Does that mean that our bleeding risk decreases also, or not necessarily? Like, explain to us why there's a drop in or an increase in dosage.
So for those drugs specifically, Eliquis and Xarelto, we give the higher dose initially because we're trying to get the body to the level that we need the drug to be at as quickly as possible. So after a week of Eliquis at the higher dose, we get you to what we call the steady state based on how the body processes the drug and balances everything, that is then maintained with the 5 milligram dosing twice a day beyond that. So theoretically, there may be some increased risk of bleeding with the higher dose, but probably not in reality, because it's more about getting enough drug into the body that it will do its thing the way it's supposed to. And actually, the initial period, we're much more worried about another blood clot because the body is already stimulated to have done it once. And if we don't provide the appropriate protection, it will do it again in the short term. So we take on a little bit of a risk potentially, although I haven't really seen issues with bleeding that short term. I'm more worried about it long term. We worry more about clotting in the short term. Sorry.
I know you're getting over laryngitis, so thank you very much for joining us with laryngitis this evening. You need to see a doctor. Okay. All right. So that's very helpful in terms of, understanding that process, because a lot of times we're like, well, why is it being decreased? Are we protected? And if it is being decreased, does that mean that our bleeding risk actually decreases as well? So I think that's great. Okay. Todd?
Yeah, and I saw somebody in the chat mention, some kind of a training that they could take to help stop the bleeding. And I just want to say that the wilderness first aid course that they give through the Red Cross is absolutely wonderful because it concentrates on that heavy bleeding for when you're away from home. But I think you guys should check out that also. Jacob, I want to talk about drug interactions really quick. People get really confused when I tell them I'm able to take an NSAID on guidance from my orthopedic trauma surgeon and my hematologist. I just can't pop them like M&Ms, but there's a plan. What do some drugs combined with why do they cause bleeding? So if someone was to take a lot of ibuprofen, too much ibuprofen, or ibuprofen without approval, and they have a bleeding incident, what actually causes that bleeding to start with that drug? And which drugs are the biggest culprit? And can you really not take an NSAID with an anticoagulant for fear of bleeding?
Yeah, that's a good question. So the major issue in general is that drugs are all metabolized, so broken down by the body and digested and disposed of. And if someone's taking multiple drugs that are metabolized by the same thing, then their levels can build up. Or on the other hand, sometimes people are on drugs that increase metabolism and they can break down the blood thinner too fast, and the blood thinner won't have its effect and you could have another clot. So very important, number one, for somebody to review all your medications when you initially start the drug, but also if you start taking a new drug regularly, then you should let your doctor or whoever's seeing you know so that they can reevaluate if there could be an impact on your drug level. In terms of NSAIDs like ibuprofen, those affect those blood cells I talked about earlier, the platelets, and decrease their function. So the issue is that those two effects can be additive, and then that can predispose people to more bleeding. I don't worry too much about a dose here or there. And actually, there is a type of NSAID called Celebrex that we prefer to use in people on long-term blood thinners. And if you can talk to your provider about that, because there may be a role for using that drug if you need those kind of things. But again, I don't personally worry about taking something like Advil here or there, certainly not regularly. And if it's rising to that level, I would talk to your provider about it. But so another class of drug I wanted to mention that's very common that can have an issue are antidepressants like SSRIs. So those can affect bleeding risk in the same way that I mentioned with the with ibuprofen, and that they can affect platelets. Not as consistently, but they can. And so those are important drugs to let your doctor know about as well if you're on a blood thinner. And also supplements. There are some supplements, St. John's wort, things like that, that can increase bleeding risk. So those are all important to mention also.
But
Now, can
dosage?
I ask one question? I'm sorry.
Yeah.
Can I run to get a cough drop? I think that
Oh,
will
of
help
course.
me sort of rally and,
Yes.
continue to
Absolutely.
preserve my
While
voice. I'm very
while
sorry
you're,
about that.
no, go right ahead.
Absolutely.
While you're doing that, Todd, walk us through the wilderness first aid kit that you were talking about.
Well, I took wilderness first aid training for my job because I'm working on the river a lot and in remote woods, and they just go through how to stop more major bleeding, um, the amount of pressure to use, the things to have in your trauma kit. Because if you're going to go out camping and you're going to go out bike riding or doing overnighters on the
Yeah.
river, something like that, you really should have a trauma kit. But it goes even farther than that because it shows you how to apply a tourniquet to yourself. And I mean, most of us don't know how to do
No,
that.
I
So,
wouldn't know how to do that.
and the Red Cross classes today, the general ones, are really watered down. They don't really focus on that heavy bleeding stuff. But if you go a bump up and take a wilderness first aid class, I think that's really good training. And I also want to remind everybody, wear a medical alert ID,
Yeah.
especially if you're going to go out and you're involved in activity. So every time I go for a bike ride, I'm wearing my ID, and it gives the dosage, the name of the anticoagulant, and of course stuff like emergency contact and your name. But I think those two things, the wilderness first aid course that you can take at any local Red Cross, and having the medical alert ID or a military tag, anything that tells medics in case you're unconscious, if you can't talk, it's really good when those medics show up that they get a head start and they know what you're on, right?
Yeah,
They
no,
know that you have a problem.
I think that's a great idea. And a couple of folks have also mentioned, it's like a spray-on Band-Aid thing that is good at preventing bleeds
hmm
as well. So, I mean,
Yeah, and there's stop clot. There's all kinds of different
right,
products that
exactly.
you can put in the trauma kit. And really, I think one of the more dangerous locations to me is out on the road when you're driving, right? I think every car should have a trauma kit in it just in case. So just some things to think about.
Yeah, no, that's great. Um, so we were talking about, you started talking about St. John's wort and interaction. What kind of dosages are we talking about? Because people often ask us about taking, the vitamins. Todd gets this a lot in the group, but dosage wise, like when does it become a problem?
So it's hard to say generally. Often supplements that can be picked up in the drugstore, some have modest doses, but some can have pretty high doses. It would have to be kind of reviewed by us with a pharmacist in the specific situation. And I'll say also that vitamin K, that's something that we want people who are on Coumadin not to be taking, because that can definitely affect that. Usually we don't see that with Xarelto and Eliquis, but it's another one to potentially watch out for.
And
And
just
then
explain
I
to
want to,
everyone.
while I'm thinking of it, I saw a comment about medic alert bracelets. I think
Mhm.
that's really, really important.
Yeah.
We've seen
Yes.
really bad things happen when that something, God forbid, happens to someone and they get there and their records aren't available and family's not there.
That's
And it's
right.
just one of these things I'm really making a concerted effort to make sure people do if they can. So
And we preach
strongly
hard about
recommend.
that. We preach hard about that in the support group. It's just one of the things that, and so once in a while, a doctor will bring it up with the patient, which is really
Yeah,
cool. But most of the time, they're not passing along that
Yeah.
information, and they really
Yeah.
should be.
No, that's why what you do is great by helping and advocating for people. Sorry, Leslie, I think you were asking a question.
I have so many questions. I don't even know like where I am.
There's a ton.
So before we move on though, we wanted to talk about procedures. And so anything from surgery to breast biopsies to dental procedures, you're having a tooth removed, you're getting your teeth cleaned. When do you come off? When do you not come off? What are the risks associated with all of this?
So another reason that it's important to have an ongoing relationship with someone, a provider who can help with these things, because for most procedures, what we generally recommend if you're on Eliquis or Xarelto is holding it for 2 days before the procedure. So you have 2 full days before it where you're not taking anything, and then starting it 24 hours after. And what we say is assuming the person doing the procedure is comfortable with that. So a good example is, let's say you get a colonoscopy. If they don't do any biopsies, then usually they would say fine to start taking your blood thinner that night. But if they take biopsies or even remove polyps, maybe they'd want you to wait a little bit longer. And that's usually okay. But I do have some people who are at such high risk of clotting that I'm trying as hard as I can to minimize the amount of time that they're not on their drug. And I might even have them take a dose or two of Lovenox, so an injection in
Oh.
between. I don't generally do that, but there's some situations where I might. And then with Coumadin, it's a little more complicated because for high risk blood clotting situations, you may need to do what's called, quote, bridging, where you give those Lovenox shots for a few days on either end of the procedure. But sometimes all you need to do is hold it for a few days, and sometimes you don't even need to hold it. But it's a very case by case specific thing. And again, that's why having us be able to weigh in on that and help you is really important.
Case by case is exactly right. And when you mention colonoscopy, I get the shivers every time because my only pulmonary embolism came a week after my colonoscopy. But they pulled me
Really?
off my anticoagulant for 3 days, and with factor V Leiden and me being homozygous, that was a mistake.
Mm.
You know, that was a red flag that should have
Wow.
been caught,
Yeah.
right?
Wow.
And I'll take part of the blame, but that's another story. You know,
No, yeah. I mean, it's
I should have been able to raise that flag myself. But yeah, that's a really good point.
Okay, so we did want to circle back to, we started to touch upon it, but menstrual bleeding on an anticoagulant. And why that actually causes increased bleeding, and how does somebody know when too much blood loss is too much blood loss? What do they do about this? And you mentioned iron deficiency. Does it depend if they're on a higher doses versus a lower dosage or not? I will tell you, me as a patient, I experienced this and I received no information about what was going to happen, and it was really scary. And so for those that, are menstruating, why is this happening? Because they're not necessarily, being cut.
Yep.
So how does this all work?
I mean, it's a good example of how any situation where you would bleed, whether you cut yourself, whether you're having your period, you're going to bleed more generally because you're on the anticoagulant. And because it's your body is just not plugging things up the way it normally would. And what we find with women who menstruate, even who aren't on blood thinners, is that often they will say, oh, my period is normal. And then when we do a more structured kind of assessment of it, you'll find out you're changing your pad or tampon every 2 hours and your period lasts for, more than 7 days. We wouldn't consider that normal. But I think a lot of women, unfortunately, kind of the default is to think, oh, what's happening to me is normal. And we try really hard to advocate for finding out when it's not normal so that we can help. And, the thing that we worry about is iron deficiency. And in extreme situations, iron deficiency and anemia from losing too much blood. an iron deficiency, whether you have anemia or not, can cause a lot of symptoms: hair loss, mood changes, fatigue, weakness. It's very easy to treat, but it's the kind of thing where when we have someone who has periods who is on a blood thinner, this is even more likely to happen to them. And that's something we want to be watching out for and checking for from time to time, because people may not even report symptoms, but we check because, oh, they've been on a blood thinner for 5 years and they're continuing to have periods and they're super iron deficient. And then we treat it and they say, oh my God, I can't believe how much better I feel. I had no idea that all these things were happening to me. So and so I do think there's some data that Xarelto versus Eliquis, Xarelto may have less menstrual bleeding than Eliquis. I need to double check that.
Yeah, please do, because we'd love to put that on our site because we have information, about bleeding during menstruation. So if we had more data around that, that would be great. Is there anything that women can take while on their blood thinner to reduce the level of bleeding?
It depends. There are some situations where we might have somebody take a drug to help reduce blood loss during heavy periods if they have to be on a blood thinner. There are drugs called antifibrinolytics, such as tranexamic acid or things like that. It's not common, but sometimes we do that. But it actually brings up another point, which is estrogen is known to cause blood clots. And I bet there's some people here who that was the cause of their blood clot initially, being on an estrogen containing birth control or something like that, or estrogen therapy for menopausal symptoms. And what we see too often is that what will happen is someone will have a blood clot, they'll be put on a blood thinner, and the estrogen will be stopped. You can keep taking estrogen, you just have to be on a blood thinner. So let's say someone has a blood clot from estrogen that they're taking for menopause and they're treated for 3 months. We would then say, you can keep taking the estrogen if it's helping you. You could keep taking it for years. We would just want to keep you on a blood thinner for as long as you are receiving the estrogen. And then when you go off the estrogen, you can stop it. But that's a situation we see come up a lot. And, people are like, please let me take estrogen again if I can, or they don't even know that they can ask because they're worried about blood clotting. But if you're on an anticoagulant, you can do these things.
Do you have to increase the dosage? So you don't have to go from 10 to 20 milligrams?
Not necessarily. There are some situations where you might, but not necessarily.
Okay, so this is really something that needs to be obviously well discussed with your doctor. But there are options for women to explore. So you should be having these conversations with your doctor. So like I was told I couldn't go on HRT, which is hormonal replacement therapy, because I'd had a blood clot. I'm unprovoked. I'm on an anticoagulant, but the reality of the situation is I probably could have. I could
Yeah,
have.
I would say that would not be what I would say to a patient who brought that to me. I would say probably you can. Maybe we'd look at the dose or look at the specific dose of estrogen that would be given in hormone replacement therapy, but usually we can do it safely.
Okay. Todd, can I make a suggestion here?
Mm-hmm.
Because we have all these other questions that we wanted to ask Jacob.
Yeah.
What if we do a real quick update on the factor 11A? And then let's move into questions because we have so many
We have a lot of questions.
webinar.
Yeah, I
and
want to
we've got
get more
so many
questions.
questions that people have sent in, and I really want to get to people's questions.
Yeah, yeah. Well, and that was going to be my next question anyway, was, and people are get really excited about possible new anticoagulants. So is there any update, Jacob, for us on factor 11A? Perhaps explain to everyone what it is and where these new drugs stand. I think, is it Anthos is phase 3 and Regeneron will be moving to phase 3 at the end of the year. Will they be like the holy grail of preventing blood clots without a lot of that bleeding risk?
So that's the hope. I don't know if it's going to play out that way. The reason that factor 11 is appealing is because it's involved in blood clotting, but it's not so essential. So if you have a drug that affects its ability to work, the body, basically, the more essential something is to blood clotting, if you block it with a drug, then proportionally you're going to be at more risk for bleeding. So Eliquis and Xarelto block fewer things than Coumadin does, and that's probably why they have less bleeding. And what we're trying to do with the factor 11 drugs is go even further out to a less essential part of blood clotting than Xarelto and Eliquis affect to hopefully, and I think what we've seen in the studies so far is that there is less bleeding with those drugs. What has not been so consistent yet is how protective they are against blood clots. I think actually the phase 2 data is pretty promising for it's been specifically studied in preventing blood clots after orthopedic surgery, and it's been fairly promising with that. In terms of being given for something like atrial fibrillation and preventing stroke in different trials, not as sure that that's showing what we want it to show. So I think there are some phase 3 studies going on, and that will be really important to see if there is potential for these drugs. I don't know that we as hematologists are sort of expecting that they're going to be the holy grail the way that they were initially talked about. And I also want to say that we're pretty happy with how Eliquis and Xarelto work, except for the cost. We hate that. That's probably the worst side of obviously bleeding, but just that we know that the manufacturers and the drug companies are taking advantage of people with that is really not great. But they are good drugs, and we try to help patients with finding copay assistance and certain programs they can apply for. But I think the point being, it's always good to try to find new things, but these drugs seem to be a tremendous improvement for people over Coumadin and the injectables. So we hope for better, but we're not necessarily saying we have to have better because our patients are not going to be okay until we get it.
Right.
No, that's a great point.
Yeah, makes sense.
We as an organization will keep everybody updated in terms of what's coming down the pike. So there are a couple that are in phase 3 or coming into phase 3. Regeneron, which is a company that's in manufacturing mode for the new factor 11A drugs. Anthos Therapeutics, which is another one. J&J had a drug, I think, that failed initially. And then while we're talking about the DOACs, a quick question for you before we move on. So Eliquis is coming off patents in the next couple of years. What does that mean?
Hopefully, that means that other companies can make generics, which are essentially the same drug made by a different company, and then the companies can compete with each other for who can make it the cheapest. And then that will mean that you all can get those drugs a lot cheaper. And that will be a humongous improvement. And that honestly may even take a lot more pressure off of the factor 11 drugs and things like that, because again, we usually see people do really well with these drugs.
Yeah.
So,
And will it have the same efficacy as Eliquis now?
you always worry about that a little bit, but I think in general, it's not so hard to manufacture the same chemical by a different company. I always buy the generics at the drugstore. I don't need to buy the brand because I'm confident that the generic is going to be the same. So I think you can be confident that the generic one will be just as good.
Okay. Well, we will be anxiously anticipating all of these coming down
Yeah.
the pike and report back in. Todd, do you want to take the first set of questions? And
Yeah, I'm going to ask one that we talk about in the group a lot, and this question did come in from a patient. It's on the list here, and I'm involved in this as well, so I'm curious about your thoughts. We talked a little bit earlier before we went live about being out and doing your favorite activities and having that fear of bleeding. And someone wants to know, look, I've got questions about rock climbing, skiing, ice climbing. I'm a mountain biker. I ride about 200 miles a week. I take precautions, but what do you say to people that want to go out and they're afraid to do some of the activities that they used to do. And so they're walking on eggshells and they're not really going out and doing much at all. What do you say when somebody says, hey, is it okay if I go for a bike ride, or can I go hiking? What can I do? What can I do? What do you tell them?
Yeah, so it's a very common and very reasonable concern that patients have is, if I start exercising while I have a blood clot in my leg, am I going to make it break off and go to my lungs? You can totally understand that concern. We feel, and it's backed up by our experience, that if you're on the drug, you can do, well, you don't have to worry about exercise in most cases. You can walk, you can run, you can ride a bike, you can do the things you want to do, and you should. I mean, that's, your ability to live with what has happened to you and that you may be on a medication long term, that's a significant psychological burden potentially, and it's going to be, lessened if you can feel like yourself again. And we really feel strongly that people can and should be active and do the things they want to do. You should wear a helmet in situations where you can hit your head, bike riding, horseback riding. Leslie, I know you brought that up. We generally say you shouldn't go skydiving, and we say that a little bit as a joke, but you brought up some activities that are a little more, I guess, extreme. Skiing, there's a potential for injury, things like that. And I think then you get into a discussion about, as long as you're understanding and accepting of the risks involved, there's not much that we would say you can't do. Wearing a helmet, maybe a little more than you might normally. Maybe you don't participate in contact sports the way you might have otherwise, but some people do, and some people feel comfortable, understanding the risk of taking that on because it's important to them. And it's not the kind of thing where we see that everyone who does this stuff has bleeding. I'm sure there's people who skydive on these drugs who don't have anything happen to them. So I think the main point is that we see people restrict themselves much more than they need to because of fear of bleeding or causing more blood clots.
Well, I'll tell you what, I skydive. I skydive quite a bit. I'm more worried about the parachute not opening, right, than hitting my head where I've got a helmet on.
Yeah.
But yeah, some of those activities people still can enjoy, and I think it's important that they do so, because mentally, that's a big boost to get back to your life a little bit. You just may have to slow down a little bit, right?
Yep.
So, okay, Leslie,
All about risk reward and understanding what the risks are, so you can,
risk versus benefit. Yeah.
make informed decisions. And if you're not given the information to begin with, how are you as a patient going to be able to make a decision about what you can or cannot do? So thank you for putting it so eloquently. One of the questions that came in is, I know you all on the clinical side love the DOACs, and for the most part, it's pretty good for patients as well. But they haven't been around that long. Do we know what the long-term use of DOACs is?
Yeah, so it's a reasonable concern. We have, so they've been around since I think 2010. We have yet to see any sort of, okay, this person's been on Eliquis for 10 years and now they're developing this new medical condition. And, I think the thing that's really important is that the way they work is to affect the body's ability to clot. So the main side effect is bleeding. That was what we've seen historically with Coumadin, with Lovenox, heparin. Heparin's its own thing, but that people who are on these drugs for a long time, the main thing that can limit them and the efficacy and side effects is bleeding. I can't say for sure any drug, there is a theoretical risk. I have had very, very few patients who had a side effect that wasn't bleeding that I ultimately felt like was related to Eliquis or Xarelto, and then I just switched them to the other one. But again, really, I have so little evidence that they do anything other than they're hard on your wallet right now and they put you at risk for bleeding. I don't know what the case is going to be in 20 years, 30 years. We'll have to see. I hope nothing, but there's no signal at this time that there's a reason to be concerned. And in more, I see situations where people are worried about that and they don't want to take anything. And I really worry that they're going to clot. again.
Right.
That's a much bigger concern.
Because once you've had a blood clot, you're at a slightly elevated risk. Moving
Yes,
forward,
with the
right?
caveat that's it's easy for us as medical providers to prescribe medicine, right? So it's easy for me to say, okay, take this blood thinner and stay on it, and then I've quote unquote done my job. But I think we probably overtreat people, and I try hard to figure out when somebody can be confident that their blood clot was circumstantial, and if they take precautions in the future, they don't have to take it every day. Again, a theme I keep coming back to is a relationship with a provider who
Right.
can, assess this with you over time.
Right. So let's stay on side effects because this is a big one. And I've been wanting to ask you about this. It is in the group almost every other day. Okay. Some people experience it, some people don't. And I kind of want to know why, or if it has anything to do with the anticoagulant, and that is hair loss. Okay, we have a lot of people that complain about hair loss. Doctors sometimes tell them it's the mental trauma, that there's something that can cause that, and that can stay in effect for 3 or 6 months. But do you know of any connection between the anticoagulant and people losing their hair thinning, things like that?
Not about the drug specifically. I really can't say I've seen a situation where I thought that the drug itself was causing that to happen. I brought up iron deficiency before. Iron deficiency can cause hair loss, and that it could be that the effect of the blood thinner is that you're losing blood without realizing it, and that's causing iron deficiency, which may be causing hair loss. That said, I'm not decades into my career. It's possible that this happens. I'm actually looking now at the package insert for Xarelto to see where they describe hair loss as a side effect. And I'm
another
not even
another thing that I've noticed though, and we have more women in the group. Just we love to talk about stuff, and I've noticed that more women in the group than men. But I've noticed that men don't complain of hair loss as much as women, so that tends to fit the iron issue. Maybe that maybe that does have something to do with
it's
it.
just a thing that's very easy to check for, and if it's there, it's very easy to treat, and then you don't have to go off your drug. But I do see that less than 1%, but there are reports of hair loss with these drugs. So, we have 200 people in here. That means probably could be multiple people have had this happen. I
Oh,
would
yes, and they're commenting on it right now. And so
Yeah.
just the fact that you're acknowledging it, because most clinicians go, no, it's not a risk factor. It is.
It is.
For sure. It could, I think it's not common, but I think it can happen. And, you would then look at a different Eliquis, switch to Xarelto, even look at Pradaxa or other similar drugs. And, again, this is why it's good for me to do this. I'm seeing all these comments. I would advocate for checking iron, but then I would have to consider switching.
Right. Right.
A lot of questions. I know we touched upon long-term usage and what does that mean, but a lot of questions on what are the DOACs impact on my kidneys?
Yeah. So we don't necessarily see them cause kidney damage. But I think the main issue is actually the other way. If you have kidney disease that progresses over your life related to diabetes, related to high blood pressure, that can affect the safety of taking these drugs. Eliquis is better for kidney disease than Xarelto, but at a certain level, all these drugs become a bit dangerous, and it's just important to be making sure because that increases your bleeding risk if your kidney function is worse. And so it's not so much that the drugs cause it, but it's more that you really have to be careful with them and potentially choose a different kind of drug like Coumadin if you have advanced kidney disease.
Okay. Great. Todd?
So again, here's another question that pops up in the group a lot. And I've done this myself. I don't know. I can't even tell you how many times. I'm in the kitchen, the cupboard door's open. I bang my head on the corner of the door. Okay. Do I need to go run into the ER? Should I go get checked? Or is that only for if I fall down the stairs and hit my head on the concrete? There seems to be, there's a lot of confusion there because the doctors aren't telling them up front, hey, if you do this, go ahead and get checked. So that they leave kind of confused. But if somebody just bumps their head on the car door frame or a cupboard, should they be concerned? Are there signs that they should look for? What's your opinion?
Yeah, so it's a tough one. I generally would not be concerned if you're bumping your head on the car door, on a countertop. If a few days later you're saying, "Oh, I've got a headache that's not going away," or "My vision's a little off," that would be a sign to go. But just because something like that happened, I wouldn't go check. Now, if you fell down a flight of stairs and smacked your head, certainly if you lost consciousness, but there's a certain level of intensity of the impact where you'd start to say, okay, actually, in that situation, you should go and get a scan to be sure, because significant trauma when you're on one of these drugs could cause bleeding.
And when you think about our body, the skull and the rib cage are actually pretty cool. I mean, they're there for protection, right? The ribs are protecting
Exactly.
your vital organs,
You will.
your skull's protecting your brain, and you got to give it a little bit of credit. But yeah, in this time, at this time of year during the winter, falling on ice, you smack your head on ice, you
Yeah.
should probably get checked out. I mean, that's
Probably.
a pretty significant hit. Okay,
And the language you used, getting checked out, you don't necessarily need to go to the ER. You could call your doctor, tell them the situation. They might be able to coordinate a scan for you without you having the horrendous experience, which I'm sure many of us have experienced, of going to the ER and paying more because it was done in the ER as opposed to outpatient. So there's degrees of it, but there are some times when with a significant enough trauma, even if you feel relatively okay, you're on a blood thinner and we might still want you to get checked.
I think it's more scary in the beginning, but I think after,
Mm-hmm.
I've been on it for, over a decade now. So it's like I have a handle on it, but at first it's a really scary thing. Okay,
Yeah.
Leslie?
Getting the scan, does that require contrast?
Sometimes.
Because that's another concern for people, is making sure you're not having contrast too often. I'm not sure what
Yeah.
too often means, but that is a concern. Another question for you. People wanted to know, does alcohol use increase the risk of potential bleeding on an anticoagulant?
I think on a basic level, no. I think the concern would be if you're drinking enough that it would affect your liver, then potentially yes. And also, if you're drinking and you're less coordinated and you fall or things like that can happen to you, it's more about what alcohol does overall than what we were talking about with the ibuprofen, that directly affects something that affects the blood's ability to clot. Not so much alcohol on making your blood quote unquote thinner, but more about sort of the impact of alcohol in the body in general and what that can do over time. But I think people can and should go ahead and, social drinking, a glass of wine, you shouldn't
Probably
restrict
okay.
yourself of
I,
that.
I, I think doctors usually say a couple of drinks, because that's the other risk, is if you have three or four and you start getting uncoordinated and stumbling, then you're going to get hurt easier. That's
That's
another
what I'm
reason
more
to wear a
worried
medical
about.
alert ID, right? If you're going to go out drinking
Yeah.
socially, I tell people, wear the
Completely.
ID. Wear the
Yes.
ID. Yeah.
Okay.
Can I have another question, Leslie?
Of course.
So this comes up often as well.
I just took another cough drop, so I'm ready to go.
Are there any food alternatives that you recommend, or any holistic way? What about all these supplements? What about natto? What about things like that? Are those effective for people? What about the people that want to take those because they have, no bleeding risk? How do you feel about that stuff?
No, there's not. And I get a question a lot about, is there anything I can do to reduce my risk moving forward? There's not really a supplement or anything like that that will help. And it's the kind of thing where in some situations there can be harm done. And so I really strongly recommend talking about supplements you take with a provider. But in terms of the specific ones, I can't so much recommend that one is going to help. but there's certain ones, St. John's wort, and things like that, that can increase the bleeding risk.
Okay. I think what we're going to do is 2 more questions, one apiece, before we let Jacob go. And I just want to remind everybody tonight that we're actually not giving medical advice. This is an educational format to give you the material and education to go and have the conversation with your provider directly, because everybody's situation is different. And so that's really important for people to understand that. So, and also, we're sorry that we can't get to all of the questions. We need to go back and go through a lot of these and see if we can create some responses for folks and put it on the website. We'll have you back to do another one of these.
Please,
to
yeah.
continue the conversation. Final question on my side. I just finished 6 months of Eliquis. I'm now on a baby aspirin, 81 milligrams. Is the bleeding risk of baby aspirin the same as Eliquis?
I would say no. I would say it's less. But the blood clot protective effect is not as great as with Eliquis.
Yeah.
I don't know the specifics of the situation. Sometimes we see people do that where there's a little bit of uncertainty about whether someone should take the blood thinner beyond 6 months. And so maybe they compromise with a less intense one like aspirin. And I think that's potentially okay. But, again, to answer the question, less bleeding with aspirin, but not as much protection against blood clots.
Okay, thank you.
Okay. Now, my final question is, I don't think this is asked too often, but again, I'm going from what I see in the groups and have seen in our group over the years. Families like to go out, they like to have fun, they're trying to focus on fun and just being with each other, and they want to go to Disneyland and they want to go to the amusement parks. And I've actually seen a lot of people be very concerned because they've heard something about riding on a roller coaster while you're on blood thinners. What can they go for a roller coaster ride?
I haven't heard that one. And I would say yes, please go on the roller coaster. I mean,
Okay.
again,
I don't even think you'd have to wear a helmet. Just strap yourself in and go for a
no,
roller
that
coaster
one
ride.
I can't. But I mean, it does speak a little bit to the worry about being quote unquote normal, or like resuming normal activities,
Right.
because you think, I had this serious thing happen to me. How do I know what's going to put me in danger? And I think, that specific situation I would not worry about at all. And I think it just speaks to the broader, it's not just about protecting yourself from harm from your drug or from another blood clot, but it's also what providers should be doing is helping you, live well. And with these kind of concerns, hopefully they can make you feel better about them and give you permission, so to speak, to do the things that you might be worried about. And that's to me just as big a part of our job.
Yeah,
Thank you so much. That is right on. Yeah.
I learned so much from you tonight, and I think one of the most important things is to try and have that relationship and dialogue with your clinician who can give you these kind of responses. Because I know as a patient, I did not get the information, that you're giving out so freely tonight. So thank you very much for everything. Thank you to everybody who joined this evening, and to the NBCA team who is behind the scenes, posting all kinds of great information. The next talk is the PEP Talks are every Tuesday at second Tuesday of every month at 7 p.m. Eastern Standard Time. Our next PEP is actually going to be on family history, which plays a very, very big role as well for blood clotting. So we hope to see everybody then. And in the interim, have a wonderful holiday, a happy new year, stay safe. And thank you all for your support of our organization. And Jacob, again, thank you so much. We look forward to having you back.
Please,
Yeah, thank you,
so
Jacob.
much for
Thanks,
having
everybody.
me.
Good
It
night,
was great.
everybody.
Good night.
Good night.